Right. So my sense is that you all do have a fairly good idea of what populations, what clinical context indicate in-person services rather than telehealth. One of the things you want to do with that, of course, is well, before we get to that, in each environment where you're choosing to see a client in person, it's going to be really important to document in that client record why in-person services were indicated over telehealth. And again, keeping in mind that right now, telehealth is the default, and recognizing that meeting with clients in person does create an additional risk for both the client and for you and for the population at large. And so what we need to be doing is documenting explicitly why that risk of potential exposure is balanced out by the need for the client to have in-person services rather than services via telehealth. So that's the place to start. Is one of the reasons we're running through this is to really be mindful about identifying why am I deciding that telehealth is indicated for this individual client, and then being able to document that in the client's record. So once we've decided that telehealth is appropriate for a client, and it is that the risk of, in-person, when in-person services are appropriate for this particular client, and the risk of in-person services are outweighed by the limitations of telehealth, the next thing we want to do is think about how do we have safer standards to meet with clients in person. And the parentheses around the R there is, of course, we cannot ensure absolute safety. We cannot, and it's really worth keeping in mind that if we are interacting with anyone in person, we cannot guarantee safety. There's always a risk of infection. The place to start with this was the CDC guidelines on April 8th. So now we're looking at several months ago, as this was all sort of unfolding, the CDC issued some really general guidelines on if you are essential, which, remember from that March 23rd order, we are considered essential services. If you're essential services, here are some of the minimum standards that you should be taking to minimize risk of infection. So at a minimum, pre-screening yourself before each workday, of assessing any symptoms that you might have and taking your own temperature. One of the things that I really recommend too with taking your own temperature is to keep a log at the beginning of each workday of what your temperature is. And what this is doing is it's documenting that you are taking steps to at least try to identify if you might be sick. Now remember, if you don't have a temperature, that's no guarantee that the virus isn't present. But it does show that you're at least taking the minimum steps to assess and to not see clients if you do identify some symptoms. In addition, wearing a mask, you'll see from some of the additional guidance that we'll run through that really wearing a face covering is becoming the absolute default standard. We'll talk a little bit about what to do if that's just not feasible, but at this point it really makes sense to assume that you and the clients will be wearing a mask. At the same time, keeping social distancing as much as you can. And remember, this is a minimum of 6 feet of space. More is good if that's possible. And then disinfecting and cleaning any shared or common areas. So this really is the minimum standard. In addition to this, we've got several Washington state guidelines that have been released over the past couple months. So this one is the governor's proclamation on returning to a safer provision of non-urgent medical and dental procedures. Now, this does not specifically apply necessarily to outpatient behavioral health, but this provides us some really good guidance on what are the appropriate standards for healthcare providers who are seeing clients and patients during this time. I've got links in the presentation to all of these sources. I'd really recommend that when you have some time that you go back and read them, and also just stay on the lookout for changes, because there are new standards or new guidelines being released on a pretty regular basis. A month ago, I think I would have probably said that wearing a face covering, wearing a mask in a clinical session um, really was best practice, but was optional. Given what we're seeing now, I think I would say that wearing a face covering in a session really is the standard, and you'll need to absolutely be able to articulate why that wasn't feasible if you and the client are not wearing masks. Yeah. So the first one there is having some signs that inform your staff, your clients, any visitors about just general good hygiene. And some of these signs can be downloaded from the King County Public Health website, also from the Washington Department of Health website. So there are sort of ready to go signs that you can just download and post. In addition, one of the standards that we really need to be educating our patients about the risk of infection, and this needs to be in language that's understandable to our clients and patients. And we really want to be helping them understand what the symptoms are, what the risk factors are, and how to prevent the spread of the virus, including things like hand washing and face coverings. And again, a lot of these materials, you don't have to just try and create these yourself. You can access these through County Public Health or through Washington State Public Health. We also want to make sure that we are maintaining that social distancing as much as we possibly can. Means is things like not having multiple clients in a waiting room at any one time. One of the standards that's really kind of developing is having clients arrive and wait outside the building until they can be allowed in one at a time for the session. Even moving sessions into locations where maybe you have more room. For example, considering something like if you have a waiting room that's larger than your office, you might be able to hold sessions in the waiting room. Now, I recognize that there's other complications that might make that difficult if there's multiple clinicians using the same space and just one waiting room. But really thinking about, are there spaces that you can be using where you'll have more space between you and the client? We also have some guidance on cleaning and disinfecting the common areas and the high touch areas. Also keeping in mind that if there's any reason to suspect that someone who is COVID-19 positive has been in the office, then we really need to do a deeper disinfecting clean. And again, remembering that these are not necessarily laws, these are guidelines on how best to minimize risk if we need to see people in person. We also, if we've got employees, really need to address strategies for addressing what we do if they've been exposed. And of course, training your workforce on best practices and safer interactions. One of the really interesting things from this Washington State guideline is a recognition that there is variation in the geographic context, in different aspects of the healthcare system and the capacity and the challenges that they're facing. And so what this is saying is that these are guidelines, but it is essential that we as healthcare providers really use our own discretion and judgment to evaluate what's in the best interest of our clients and what are the risks that we're facing, and to do our best to take reasonable action to balance out the risks of infection versus the risk of inhibiting the clinical services that we can provide to clients. We also have some other guidance. So this was some guidance that came out in May 29th for entering phase 2, and this is opening up to additional professional services. Now, this guidance is not specifically addressing healthcare. This is more focused on other office-based professional services that will start to be able to open up in phase 2 that we're not able to be operating while we're in a complete lockdown. However, this is really useful guidance given that that office environment is very similar to what we are doing in a lot of our behavioral health practices. One of the things that is key in this guidance is the focus on face masks. That the standard here is saying face masks really need to be worn by everyone when there's any kind of interaction. And again, this is part of what's making me feel like the standard really is face coverings, and any deviation from that needs to be clearly articulated of why that face covering was not safe or feasible for your individual client. Okay, so here's just some links to some additional guidance. The CDC put out some guidance on May 18th on how to enact best practices with regard to minimizing infection. We've got some King County guidance from just a week ago or so, specifically about behavioral health providers. This guidance from King County appears to be much more focused on behavioral health in a hospital or a primary care setting. The standard from that King County guidance is that face masks need to be worn all the time in any interaction. So I think that we really are seeing that becoming our standard. Okay, so before we get to the alternatives, I'm just going to look through the chat real quick and make sure that we're addressing the questions. And yes, you will get a copy of the slides. Those will be sent out after the presentation. Let's see. Oh, here's a really interesting question. So a question that came in was, can we choose to refuse service if someone won't comply with wearing a mask or with taking their temperature? It is really interesting. I would say the simple answer is yes, and the more complicated answer is kind of. So the simple answer is you wouldn't refuse services, but you absolutely could tell a client that you are not able to safely provide them in-person services unless they comply with your policy. Your policy may be to take their temperature and report it and to wear a face mask. And the client has every right to say no, every right to say no. And if they say no, your response may be, then I'm not able to safely provide you in-person services, so the option is telehealth. Right? So you're not refusing services if the client won't comply, but you are informing the client that if they are unable or unwilling to comply with your policies, you are not able to provide them in-person services safely. Seeing questions about if a client does not want to be seen via telehealth, what do I do? If I'm not going to see clients in person until, say, phase 4, that likely is going to be months from now. What do I do? And that's difficult to say. I think on a case-by-case basis with your clients, I think it is important that we recognize that for many clinicians, in-person services are not going to be resuming anytime soon. And so what that really means is reassessing with the client, given that this is the long-term situation, do we transition to telehealth and just do the best that we can? Or if telehealth is something that the client is not willing to do we then terminate? If you terminate, it would make sense to provide some referral resources for in-person services. That might be really difficult, but what that might look like is, in case of an emergency, there's always a hospital emergency room. For in-person services, you could refer your client back to their insurance company and say, I don't have referral resources right now for in-person, but you can contact Primera and see if you can find some resources for in-person. What I think is a little bit dangerous is to pause clients and say, okay, if you client don't want to come in for telehealth, we will just temporarily pause the services and we'll resume when in-person is available. The risk there is we have no idea when that might be. And generally, it is not a good idea to have an active client that is an open client on your caseload where you're not having regular interaction with them. You're much better off to say, we'll terminate until those in-person services are plausible again. You have some specific question about masks. All of the guidance that's coming out, each new piece of guidance is reinforcing more and more that wearing masks is the standard. So my thoughts on this is that the default should be that both you and the client are wearing masks. If there's a reason on a case-by-case basis for each individual client that masks are not safe or not feasible, I would recommend that you articulate that in the client record. For example, a client with respiratory difficulty with breathing through the mask, a client who cannot safely remove their mask on their own if they need to. So those would be some of the safety issues. If there's a reason that wearing a mask is not safe or feasible, or with children, for example, would document that in the client record, and then I would recommend that you document what you are doing in place of wearing a mask, right? And that may be holding a session outdoors and having more space. The really important thing is to document why a mask is not feasible rather than not preferable, right? A month or two ago, I think I would have said, you can document that wearing a mask is not preferable in a clinical session. Now I think we really need to be defaulting to masks unless we can document that it's just not feasible and it's not safe for the client or the clinical work can't be done. Oh, right. So talking about that, with in-person in the office, we've got some real challenges. There's a lot of research out saying that the most dangerous environment for infection is in an enclosed office situation with recirculated air, right? That is where we likely can end up with the virus being viable for a significant amount of time just in the air. So given that that is a significant risk, what are some of our alternatives? One that I've seen many clinicians contemplating is the potential for walk and talk therapy, right? So holding a clinical session outdoors rather than in a confined office environment. With walk and talk therapy, there are a couple things to consider. One is to make it explicitly clear that the client's chart reflects that the walk and talk therapy was specifically intended as a clinical interaction. And the reason for that is to avoid the potential risk that the boundaries get blurred. And we don't want the client to inadvertently start to view the walk and talk therapy as something different than the in-office therapy. That now your clinical relationship has become something different because now you just go for walks together, right? And so the way to address that is to clearly articulate in the clinical record that due to the current risks of in-person sessions, that you and the client have decided that the clinical setting will now take place outdoors under certain circumstances, and that is a clinical interaction. Of course, also keep in mind that another alternative always is to continue with telehealth, right? What other alternatives might there be if telehealth is something that is not a viable alternative and the risks of in-office sessions are high? What other options might there be? Oh, right, and I'll just say one other thing is the with walk and talk is confidentiality. Absolutely, as Melissa pointed out in the chat, that understanding that by having a clinical session outdoors, you have less control over maintaining confidentiality. And that can be acceptable. That the important thing is that our obligation is to help clients understand the potential limitations and risks to confidentiality by holding a session outside and making sure that the client then is acknowledging those risks and choosing those risks in having an outdoor session. I'm seeing questions about tracking and contact tracing, and we are absolutely going to talk about that stuff with regard to client confidentiality. So that's coming for sure. So what other options do you all see in addition to, oh, right, here's a great one, phone, right? A phone session, absolutely. The challenges, the primary challenge with phone sessions versus telehealth. So telehealth, remember, is both audio and visual in real time. Phone is just the audio part. The primary challenge with phone is that most insurance plans do not reimburse for phone sessions to the same degree that they do for audiovisual, for telehealth. So the first issue just to think about is if this is an insurance client, how does the phone session impact the ability to be reimbursed for that? The other thing is, just like with telehealth, where there's information missing that you have in real life, with phone sessions, of course, all the visual information is lacking. But I think this is super important that absolutely is an option to consider phone sessions rather than telehealth. I also see the comment of using a group room rather than an office, a traditional office. And right on, if there's a way to just create more space, that's a great option. So with regard to exactly what kind of face masks you use, the bottom line is some sort of a face covering that covers your nose and mouth. The concept here is not to use the medical grade face shields, right, which protect both the wearer and people on the other side of the face shield. The important thing here is that we are reducing the amount of potential virus-bearing droplets that are in the air. So it's really any kind of a cloth barrier. There's a lot more guidance that you can get on exactly what is appropriate face coverings from the King County Public Health website. They have downloadable and printable one-page posters that you can post that walk through what a face covering should look like. Yeah, right, another comment. What about email? In general terms, I would say email therapy is not a particularly good option, but this is a wonderful way to sort of think outside of the traditional box. You may determine that the best way for you and a client to stay minimally connected and doing a minimal amount of work absolutely is email sessions. And again, if you're doing email sessions with clients, I think this is a really good option to consider. If you're doing email sessions with clients, the first thing you want to do is make sure that you have secure email. So don't do any clinical work with a client via just sort of the free Gmail. So if you're going to do that, you need to, at a minimum, have a HIPAA Business Associates agreement with your email provider. And ideally, you're able to do that work over encrypted email. So some of the options for encrypted email, if you have an electronic health system that has messaging or email functionality, that's a good option. One option is called Spruce, S-P-R-U-C-E, Spruce Health. They have HIPAA compliant communication, including text, email, telehealth. Another option is Hushmail. Hushmail is HIPAA compliant and encrypted email. And then there's more than these, but these are just some of the ones off the top of my head. Another one is Pawbox, P-A-U-B-O-X, which is HIPAA compliant and encrypted email. But right on, email communications might be a good alternative. Just like with phone, be mindful that email communications likely are not covered by insurance. Again, a question about, oh yeah, and another one, just opening windows. So be a little bit mindful about that. Opening windows to get more airflow in the office is a good idea. Having office spaces with fans running may actually just more efficiently spread contamination around the office. So be really mindful about that. Having windows open and venting with a fan out the window in between clients might be a good idea. Yeah. With regard to, okay, so wearing face coverings can trigger anxiety and could be a factor in treatment regarding joining. This is a really interesting point, and I would say there's, saying that wearing face masks absolutely can inhibit joining in the therapeutic relationship. That's probably not, in my view, that's probably not a sufficient basis to not wear masks. Now, you're absolutely right that that is a risk, but that risk probably does not outweigh the public health risk of not being masked. At the same time, how about this? In a specific client situation, due to a trauma history, a face mask might not be tolerated by the client. Or due to a specific trauma history of seeing someone else wearing a face mask might not be tolerable in that treatment session to that client. That's one where I would recommend that you specifically document that. And that's a case where wearing face masks may not be feasible in an interaction with that particular client, and then being able to document what you're doing instead. Okay. So one last section about sort of considerations for the telehealth piece before we move on is to keep mindful that under the March 17th federal U.S. Department of Health and Human Services policy statement, the HIPAA regulators officially said that they would relax the enforcement policy requiring business associates agreements with telehealth platforms. So traditionally, before March 17th, any telehealth platform you were using to communicate with a client needed to be HIPAA compliant, meaning at a minimum, you needed to have a HIPAA business associates agreement provided by the service provider for your telehealth platform. So what that meant was things like the Zoom, the off-the-shelf Zoom, or the non-healthcare Zoom, the one that you're getting for free or paying $15 a month for, was not HIPAA compliant. Apple FaceTime was not HIPAA compliant. Many of the other free video conferencing applications were not HIPAA compliant because you did not have a business associates agreement. Under this relaxation rule, the HIPAA regulators basically said the rule still exists. You still have to have a HIPAA business associates agreement to use a telehealth platform, but we will not enforce that rule because we recognize that there is more need for telehealth platforms than there is capacity. Now, the important thing here, though, is to keep in mind that this is still in effect. I just went and verified it before this training to make sure. It is in effect, but it will not last forever. There will be a time when the enforcement rule will go back to normal, and be mindful that you will need to make sure that whatever platform you're using to provide telehealth is HIPAA compliant. And the first step in making sure it's HIPAA compliant is making sure that you have a HIPAA business associates agreement with your telehealth provider. Okay, so let's,
Can we pause for one second? We just have a couple people with raised hand, and I was going to give them an option.
Let's do it. Okay. I was just about to say, let's take a minute to pause and talk about all the questions that we've got prior to moving on. So let's do it.
All right. Kim, I just unmuted you. Kim McLean, are you? Okay. Here, Karen, can you?
Hello. Thank you, Eric, for doing this.
Hey, Karen, for sure.
Hey, I am curious. I've got my staff, our counselors, and they want to meet with their clients outside
Yeah.
without masks. And I know there's a lot of controversy around the safety of that. And I'm not comfortable currently saying they can do that. I would prefer they wear masks. I just wondered what your thoughts were on that.
My thoughts very much line up with exactly what you said. The first one is I don't know. I honestly don't know how safe or unsafe that is, and I'm not sure that we know that.
Yeah.
I'm uncomfortable with a policy saying as long as we're outside we don't need masks.
Mm-hmm.
I think, frankly, I think I would have said that was okay 2 months ago.
Mm-hmm.
Every piece of guidance that we're getting is reinforcing that masks are absolutely essential.
Even
So
outside.
even outside.
Okay.
So I think the default needs to be masks. Any
Okay.
interaction, the default needs to be masks.
Mm-hmm.
So here's what I think maybe I would say is a consistent policy with the guidance that we're seeing, is that the policy is masks are the default. Sessions outside are not necessarily a bad idea just because you've got more airflow and more fresh air, right? And just less of a confined space.
Mm-hmm.
It is not one or the other. Being outside does not necessarily negate the need for masks.
Okay.
If there's a client where masks are unsafe or the clinical services are just not feasible with masks, I would say the clinician needs to articulate that specifically
Mm-hmm.
and document, not in general terms, but for that specific client. And then if masks are not being worn with that client, and that is the client's decision then. So if the clinician determines it's not feasible, the client can still say, I want to wear masks. And the clinician does not get to override that.
Mm-hmm.
But if the clinician says this isn't feasible, client says I agree, then I would say the clinician needs to at a minimum be documenting what alternative steps are being taken, like additional space.
Mm-hmm.
Or, I mean, I'm not even sure how feasible these are, but
Right.
more than 6 feet distance, making sure that, say, for example, the client and clinician are not facing each other, right?
Wow, that'll be interesting.
Yeah.
Okay.
And my fear is that saying we'll just do this outside without masks is actually putting people at more risk, because now the mindset is, okay, we're safer outside. And so I would want, if it were me, I would want to make this extremely mindful to say, taking the masks off, you and the client are at additional risk. So how is that risk justified, and how is that risk offset by other steps? I think that's how I would recommend addressing that.
Thank you.
Yeah, right on.
Laura?
Up, I think Laura is still muted.
Oh, hold on. I thought I just unmuted her. That's weird. Yeah, it's not, Laura, it's not letting me unmute you. I don't know if you can unmute yourself. I'll move on.
There
Marianne?
we go.
Yeah, thank you. Thanks, Eric. This is really helpful information. I have an insurance company actually that is pushing back because we are not using their mandated platform for telehealth, one that I've actually not ever heard of.
That
before.
is really interesting.
Yeah.
Okay, I'm sorry that I paused for a second. I'm actually writing that down. So I want to make sure to remember this. We're going to talk about the insurance rules at the very end.
Okay.
Here's my initial thought on this without thinking it through well enough to like feel good about this answer. My initial thought is a little scary, is that this may be a strategy for an insurance company to try and get around some of the expanded coverage that Washington has initiated. Because I, off the top of my head, and we'll explicitly think about this when we look at the insurance rules, off the top of my head, I'm thinking it's plausible that this is consistent with the Washington standards and allows an insurance company to then not reimburse a whole lot of telehealth. However, there is, and we'll see this when we talk about the insurance at the end of this morning, there is a policy under the Washington standards that basically says insurance companies are prohibited from enacting new requirements that functionally try to work around the expanded coverage for telehealth. And I wonder if that's what's going on here. One option could be to notify the Washington State Insurance Commissioner's Office, because that's who would enforce these rules.
Okay, got it.
And actually has a lot of leverage, way more leverage than any of us have. No, I'm going to put it this way. With the insurance company, you and I have zero leverage with them. The Washington Insurance Commissioner's Office has significant leverage. So that may be the place to take this. But that's really interesting in a bad way.
Thank you. I know, right, exactly. Thank you.
Yeah.
We have 2 more, so we'll take these last
Yeah,
two
let's do it.
and then move on. So Lori, I'm unmuting you right now. Let's see. All right.
Hi, Eric. I was wondering if it
Hey,
was.
Lori.
Hi. I realized I was still muted and I just unmuted myself. Anyway, is it required or recommended that when and if you do resume face-to-face, that you have the client sign a consent form acknowledging the risks and that type of thing?
Yeah, great question. And this is such an obviously important thing to talk about. My first reaction is, didn't I put that in this presentation? And to be honest with you, I'm not 100% sure, but I absolutely should have if I didn't. Okay, so here are my thoughts on the consent form. One, and this is really important to talk about, and if it comes in later, we can just go through a little bit faster. One thing I'm hearing a lot is clinicians getting sample assumption of risk or waiver of liability documents. And I think that's a really, really bad idea for a couple reasons. One is if you have clients sign a document saying, I recognize that this is risky and I won't hold you liable. Number one, that just has no legal impact. If they did hold you liable, the first thing that would happen is that waiver of liability would be thrown out for a whole bunch of reasons. The biggest one probably just the disproportionate bargaining ability of a client and a clinician. So you have an obligation to always be looking out for the client's best interest, even if you have them sign a waiver saying you don't have to do that anymore. So the first piece is, please don't use waiver of liability saying you agree to not to hold me you agree to hold me harmless or not hold me liable for any infection. Now, Lori, what you actually mentioned is the really important thing, is what we do want to be doing is clearly articulating to clients what the risk is of in-person sessions, and that risk is an increased risk of infection, right? And it's absolutely plausible that some clients may not understand that there is a risk, right? So we have an obligation to inform them of the risk. We have an obligation to inform them of what the alternatives are, and the alternatives might be telehealth or phone sessions or no sessions at all, or some options to reduce the risk like outdoor sessions, something like that. So informing them of the risks. As we talked about, clearly documented in the client record why in-person is indicated over a safer alternative. Documenting that the client then understood those risks and chose in-person sessions. Documenting what your policies and process is to reduce the risk of infection, and then a client's acknowledgement and agreement to comply with those policies. Now, none of this has to be in a contract. It could be a signed document. It could also be just a session note that says, via telehealth, we talked about the risks of in-person, the potential benefits of meeting in person, the policies and procedures that we've instituted to reduce those risks, and client has chosen in person.
Okay.
So there's no specific signed consent form that's required, but that content really needs to be captured somehow into the clinical record.
Okay. Great. Thank you.
Yeah, absolutely.
Mm-hmm.
And then I think Laura Wagner, did you have a question? I don't think so. Maybe we can move on.
Cool. All right.
You said her audio is not working. Okay. All right, go ahead and I'll reach out to her.
Okay, perfect. Cool. Okay, so then that brings us to contact tracing and confidentiality. I've been getting a lot of questions about this personally. I've also been seeing that nationally, talking with other people operating in this space, that this is a big issue that's occurring everywhere. So here's the place to start is, what is contact tracing? So contact tracing is identifying COVID infections, and then after someone is infected, identifying everyone that's been in contact with that person and tracing where the infection came from and where it's going, and notifying people preemptively to be able to have them self-isolate to stop the additional spread. So that's what it's all about. It's all about sort of just public health data to be able to track where this virus is going and to stop it before it gets widely into groups of the population. So under the CDC information, the key concepts for contact tracing is that, one, monitoring where the infection is and notifying people if they've been exposed so that they can self-isolate and quarantine, and to do that in a way that's safe, sustainable, and effective, rather than having to isolate entire populations. Now we can target and say you need to self-isolate for a specific period of time to best protect yourself and to protect everyone else. That's also meaning that public health staff in all kinds of just different jurisdictions are needing to be dramatically increased to really track down all these individuals. And there's a lot of additional digital tools being developed and deployed to really trace infections and the contacts anyone who's infected has had. So the real issue here is this, right? So your client says that she's been exposed to the virus, has a fever, and has a cough, but for legitimate reasons does not want this to be known. So you've been working with this client via telehealth, but you do know that she's had physical contact with family and friends. What should you do here? Or let me even ask you a backup question. What are the issues here? What are the concerns? Any ideas? Yeah, I mean, so the first one of the primary concerns here is there is a risk to the general population. There's a specific risk to the people that your client's having contact with, right? There's a concern about confidentiality. There's a concern about, do I have some liability if my client is infecting other people? There's also a question of, is this mandatory reporting? Well, let's look at those issues. Here's what's really interesting is, with regard to contact tracing and with regard to public health in this COVID environment, no rules of confidentiality have changed. So the exact same standards of client confidentiality that have always applied continue to apply exactly the same. So what that means is, in a situation like this, we need to return to what are our exceptions to confidentiality that allow us to disclose. And I'm really glad somebody mentioned mandatory reporting. And I do want to reinforce, there is no mandatory reporting obligation that requires us that affirmatively requires us or mandates that we report if a client is positive with coronavirus. Now that may seem surprising, but we'll talk about what the alternative is. So here's the general rule of confidentiality. The general rule that applies to all of us as behavioral health professionals is non-disclosure. And what that says is we may not disclose any confidential information, including the fact that a client is our client, without having an exception to confidentiality. And this is the big one. There's an exception that says we are allowed to disclose any information when we have a reasonable belief that disclosing that confidential client information will minimize or avoid an imminent danger to the health or safety of anyone, to the client or to the clinician or to any third party. So this is the exception to confidentiality that would allow you to disclose. The key here, and why I say this is not mandatory reporting, is that you have the discretion. That you have the discretion to choose to disclose, to minimize or avoid that imminent risk, or not disclose. Mandatory reporting says if the obligation is triggered, you must disclose or you're committing a crime. In this, to avoid or minimize an imminent harm, you are allowed to make the decision to disclose or not. Now, what happens if you choose? So if you choose to disclose, squarely an exception to confidentiality that allows it. If you choose not to disclose, then what happens, right? Oh, and I'll tell you, for anybody who's not a master's level behavioral health professional, so if we have any psychologists, psychiatrists, ARNPs, substance use disorder professionals, we've got a slightly different rule under RCW 70.02 for confidentiality, and functionally it's the same thing. You're still authorized but not obligated to disclose to avoid an imminent harm to anyone. Okay, so here's the flip side. If we choose not to disclose, this is the Washington Tarasoff standard. So this comes from the 1983 Peterson case that was reaffirmed through the recent Volk case. The Volk court said, in essence, Peterson is still the standard to apply in these situations. So the standard here is in a psychotherapist-patient relationship, you as the therapist have a duty to take reasonable precautions to protect anyone who could foreseeably be endangered by your client. So if your client, well, let's apply that. If your client comes in and says, I'm COVID positive, but I'm not going to tell anyone, and I'm in contact with people, in-person contact, and you say, well, I'm not going to do anything about that, could you be held liable for the harm of someone getting infected? What do you think? Any thoughts on this?
It seems to me that you would, because this is potentially a lethal, I mean, the COVID-19 kills people. So
I agree with you. Right on. I think this squarely, this is sort of our analysis for contact tracing and even potentially warning people in that we are not obligated to make any reports. However, if we unreasonably choose not to take action to protect someone, we could be held responsible for the outcome. And so it really is functionally a duty. So technically in Washington, we don't have a duty to warn or duty to protect. We have a duty to act reasonably to avoid foreseeable harm. But I think you're right that situation squarely falls under this standard, and this is sort of our contact tracing standard. It is not an exception to confidentiality for contact tracing. We are authorized to disclose that information under contact tracing in order to avoid a foreseeable and imminent danger to all kinds of people. And keep in mind, we don't have to know who that person is who's in danger. We just can be held liable if we unreasonably fail to protect anyone who might be foreseeably endangered by our client. So this is what does allow us and really says we should comply with contact tracing requests. And what that's going to look like, though, to keep in mind, is it's releasing the minimum amount of information necessary. And what that's likely to be is the name and contact information for a client or clients, and the time and date and duration and nature of the contact you had, which would be in an office environment on this date for this amount of time. It is explicitly not going to be releasing treatment information, diagnostic information, or detailed information about your work with the client. So okay, so I'm seeing that there's some questions in the Q&A. Right on. So the information, the question is, who do we release this information to? And it depends. So for contact tracing, generally you would be contacted by somebody either from the Department of Health or working for a governmental organization that says, we are conducting contact tracing and we need to know about the nature of your contact with this person and subsequent contacts. And so they would contact you and you would provide the information. If it's like our scenario where the client is telling you that they are positive, that they've been diagnosed as being COVID positive, and that they are having contact with people, what you might do is contact the family members to let them know. More likely though, and remember, because this is not mandatory reporting, their obligation is to take reasonable steps. Probably the more reasonable thing is to help the client understand how dangerous that is and to self-isolate and to inform the family and friends that they've been in contact with so those people can protect themselves. So that's the big functional difference between mandatory reporting and this obligation. Yeah, and Melissa, that was your Q&A. Could having the conversation with the client be the reasonable steps? Absolutely, it could be. Yeah, I'm just noticing that now after I said that. Let's see. Yeah, and if we find that we ourselves are positive, we may then need to be that's likely, it's going to be reported when we test positive, however you're tested. We then might need to disclose all of our in-person client contacts if we're the one who comes up positive. Okay, let's see. Interesting question. What if the client does not allow you to make the disclosure? It's not up to the client. So this is one where you are authorized to disclose client confidential information without their consent if you reasonably believe that that disclosure will avoid or minimize an imminent risk of harm to anyone. So client consent is not necessary under this exception to confidentiality. Yeah, and there's a comment saying, is this analogous to someone saying, I'm gonna go take a gun to school? It's very analogous to that we have an obligation to avoid the harm, even if we don't know the individual identities of who may be harmed. Okay, so I think, so I think we've got the questions. Let's see. So the question is, who would we report a COVID positive client to? So you likely wouldn't be reporting it to anyone. If they were COVID positive, whoever tested them and got the positive results would be mandated to make the public health report. You would be contacted by somebody, some public health official doing the contact tracing. Now, if the client told you they were positive and they were not informing family and friends that they were having contact with, that's the case where possibly you might then inform the family members so that they could protect themselves. Another question, is it okay to break confidentiality if you as the therapist test positive? So one thing that this is just my own kind of important thing that I think is important, is using the word break confidentiality. You will never, under any circumstances, break confidentiality. You will hold information that's confidential. You will disclose when there's an exception to confidentiality, and you will disclose information that's not confidential. But you will never break a client's confidentiality. So is it okay for you to disclose confidential information if you test positive? And absolutely, because the exception to confidentiality is you are allowed to disclose when you have a reasonable belief that you'll avoid or minimize an imminent threat of harm. If you test positive and you disclose to public health all the clients that you have been in contact with, you are making that disclosure to avoid the imminent threat of harm of your client being infected and unknowingly infecting someone else in their life. So that's the exception that allows you to disclose confidential information. Yeah, great question. And if the client expresses their willingness to inform others, are we covered? Yeah, absolutely. What you would, and again, because the same exception applies, that you can still disclose with a reasonable belief that you'll avoid or minimize an imminent threat, and the client has consented to it. So in that case, just document that the client has consented to the disclosure, and it makes your reasonableness a little bit more clear. Let's see. Let's see. Yeah, and so the question is, with contact tracing, don't they ask for names? Absolutely. They're going to ask for names. They're probably going to ask for contact information, and they're probably going to ask specifically when you were in contact, how long you were in contact, what kind of contact it was, probably. Do we need to let a client know we've disclosed to public health or to their family? Absolutely. The default should always be that we're letting the client know that we've made the disclosure. It's a good question too. If a client says they will disclose it, are we off the hook? Maybe. And the reason I say maybe is I like the way the question was asked was specifically, are we off the hook? We're on the hook if we fail to act reasonably. And so if it was reasonable for you to rely on the client to do it themselves, then you've met your requirement. If that's not reasonable, it doesn't meet the requirement. And that's so very much based on a case-by-case basis. Let's see. Clear face shields. I just can't say whether a clear face shield is an acceptable alternative. It probably is. The standard is a barrier that keeps any airborne droplets from your nose or mouth from getting into the air and able to be inhaled by other people. So a clear face shield, if it's close enough to your face, will have the same function. But again, I just don't know the science well enough to be able to say what are the best acceptable alternatives. There was also a question that asked me to repeat something, and I'm not quite sure what that was.
Hey, Eric, I just
yeah.
answered her and let her know that I would post this on our website when we were done.
Gotcha. Cool. Okay. Right on. Let's see. Let's see. The most recent question that says, should we be including this to the exception of confidentiality? My opinion is nothing new needs to be added to your informed consent form because the exceptions to confidentiality have not changed. They are exactly the same. There's no change to our confidentiality rules. It's applying the exact same rules to a really novel situation. For example, this functions exactly the same. In many ways, I shouldn't say exactly the same, very much the same as if a client came in and said, I'm HIV positive and I'm engaging in unprotected sex without informing my partners. It's exactly the same situation. That is confidential information. There's no mandatory reporting obligation. You may disclose that information to avoid an imminent threat of harm. And if you fail to reasonably take steps to avoid that harm, you could be held liable for the outcome. And so it all applies exactly the same. It may make sense to explicitly talk to clients about how these existing rules of confidentiality could be applied in contact tracing. And that is a risk of in-person sessions, right? And that may be one of the things that you want to explicitly identify to clients is one of the risks of going from telehealth back to in-person is that in the case that contact tracing applies, you may find that you need to release the client name and the times that they've been in contact with you and your other client names and times of contact. You might find that you need to release that information to the state of Washington, right? So a client probably should be informed that that is one of the potential risks of in-person sessions. So I don't think you need to change how you articulate the exceptions to confidentiality, but you should have that conversation with any clients that are choosing to switch to in-person sessions. So another comment saying, my understanding is that face shields must be used with masks by healthcare providers. In medical settings, that is the personal protective equipment standard, is medical grade masks and face shields. We are a little bit different, being behavioral health in an office setting. That being said, the best practice is medical grade face coverings. That's not mandated though. Any kind of a cloth face shield or nose and mouth covering really is the minimum standard though. I don't think that we need to have documentation clearly stating that we will disclose a client's positive status in advance, because we just don't know if we will or not. It's a case-by-case basis, right? So if a client says, I'm COVID positive, I don't want anybody to know, I'm not telling anyone, but I'm self-isolating, there's no basis for you to disclose that now. There's just, because there is no imminent risk. So that is a confidentiality. The question about could we forego masks in a large room? I would say no, that's not a sufficient alternative to masks. There are just too many variables, particularly with just ventilation in that large room. It's very possible that in a large room without masks, you could have virus-bearing droplets existing in the air for hours after that. Now, if you have a client where masks are not feasible or not safe, I think you could document that. And as one of the steps you're taking instead of masks is trying to get more space and using a group room, and then also just being mindful of how do you then disinfect and air out that room after meeting with that client, recognizing that masks weren't worn. So then, another comment, plain devil's advocate, what would differentiate between disclosing about possible COVID-19 and seasonal flu, which may be deadly to vulnerable populations? They're very analogous, with also some pretty dramatic differences. So there are lots of potential infections that could be deadly, particularly to vulnerable populations. And we have an absolute obligation to disclose those potential risks to clients. I think one thing that we're really learning from this COVID-19 situation is the importance of not going to work when you are exhibiting symptoms, even if it's just the seasonal flu, recognizing that could be deadly to some clients. So I think it is conceptually, it's just the same. It's just the risks are much higher with COVID-19. So also a question about informing client contacts. You know, if a client says, I'm not positive, I haven't been exposed to COVID-19, but I refuse to socially isolate and I'm having contact with my family, do we have an obligation to inform anyone? Probably not, because our informing the family that their client is not COVID-19 positive and is having contact with the family would not be reasonably anticipated to minimize or reduce any risk. So that probably wouldn't apply. There were a couple specific questions about the APA sample COVID form. I don't actually have the form in front of me and can't give specific feedback on it. But I would say any form that you're using, don't just use the form as is without reading it over. The things that you want to make sure is that any kind of a COVID disclosure form that you're using with clients accurately reflects your discussion with clients for your practice setting of the risks and benefits of in-person services, that it accurately reflects what steps you are taking to minimize the risk of infection, right? It clearly articulates what your expectations that clients will do to minimize the risk of infections. And then just has a statement that clients acknowledge and agree to comply. That's really what it's all about. One of the things, for example, I'm not sure if this is in that APA sample, one thing that I've seen in several clinicians' disclosure or consent forms for in-person treatment is a statement saying that clients need to agree that if they, during sessions, if they touch their face, they will immediately wash their hands. And I have no idea where that's coming from. And medically, it doesn't make any sense because it's sort of the other way around, that it's not touching your face has infected your hands that now need to be washed. I'm also not really sure how every time a client touched their face, I mean, track how many times you touch your face in 50 minutes. If every time you stop the session to have them go wash their hands, it just doesn't make any sense. My guess is that came from somebody's template somewhere, where somebody just kind of misstated it and put it backwards instead of washing your hands before you touch your face, saying if you touch your face, you have to agree to wash your hands. And I've seen that over and over again. So just be really mindful that you don't take somebody's template and just use that without really thinking through, does this all apply? Let's see. Boy, wow! So I'll get to a couple of the comments before it, but one, the EPA is suggesting freestanding room filtration systems. Do you have any opinion? I have not heard that, but that makes perfect sense. That one of the real risks, what I have been hearing, is that enclosed spaces like office environments are one of the riskiest situations because the air is being recirculated or it's stagnant. A freestanding room filtration system would be a really good idea, especially something that could replace the entire volume of air in the office in between clients. As far as how feasible that is or how you even get those solutions, I have no idea. I don't think that's a requirement at this point a requirement for reasonable interventions, but I think anything that you can do would make sense. A question about negotiating with landlords. This is a really tough one too. A lot of our office space just was not anticipating this kind of a need. And so 6 feet of social distancing just isn't feasible in some places. I know, for example, I was talking with my office mates via Zoom just yesterday, and something that just occurred to us is our office has no outside space with an overhang. And so if it's raining and clients who don't have a car to wait in have come to the office, they have to stand in the rain until they can come in for their session. So there are lots of challenges. My general advice is try in whatever way you can to work with the landlord to come up with solutions for safer use of office space. But this is a big challenge. And I know that one of the challenges for landlords is a significant portion of their commercial tenants are realizing that they no longer need or want office space, and everybody's trying to get out of leases. So that's a significant issue right now. Let's see. Yeah. Okay. So let's go on to our last section, and then we will have time to return back to questions that are outstanding. This is a fairly straightforward and short section. So with payment, The place to start, what we're really actually talking about with payment is insurance. When it's private pay, really nothing has changed, whether it's in person or telehealth. What we're really talking about is insurance. Back in 2010, the Washington Mental Health Parity Act sort of was the first in a whole line of laws that really opened up insurance coverage. So this first one said, back in 2010, that insurance companies were required to provide the same coverage for mental health that they cover for medical services. So this initial 2010 Parity Act did not require insurance companies to provide coverage for telehealth. It just said that if the insurance plan covers telehealth for medical services, it also had to provide telehealth for mental health services. So that was the first one. This is changing a lot, and policies from the insurance companies to try and keep up with the situation and with changing state laws is in flux. So I would recommend that if you are in network, just continue to check in with the insurance companies you're in network with for how to code and what coverage is looking like. But from the Washington State perspective, on March 25th, Governor Inslee enacted several specific rules regarding telehealth services. The first one was a policy requiring health insurance policies to reimburse for telehealth at the same rate as in-person services. So under the Washington standards now, telehealth must be reimbursed at the same rate as in-person services. The second one was all health plans had to cover telemedicine now. So they are not any plans that only covered in-person services now must cover telemedicine. Now, a really important distinction to put it out here, and we talked a little bit about telephone service. An important distinction is that word telemedicine. When it comes to insurance, telemedicine includes synchronous, so real-time audio and video. Telemedicine for insurance purposes does not necessarily include telephone sessions or email sessions. So that's why an insurance company can still choose not to cover telephone sessions, because that's not strictly under the definition of telemedicine. So that's the distinction why we were talking about, for insurance purposes, telephone sessions are not necessarily treated the same as audio visual or audio video sessions as well. So the requirement here is all health plans must cover telemedicine. And then the third piece of this was insurance companies were prohibited from creating some new rules that are inconsistent with these standards, broadening the coverage for telehealth. And that goes back to my thought is it's possible that an insurance company enacting a new rule that says we will cover telehealth, but only from our one selected platform, may be a violation of this standard. That might be the insurance company enacting a rule in an attempt to circumvent the coverage being provided by the other two standards. And so that's why with that specific one, it might make sense to contact the Washington State Insurance Commissioner's Office about that specific rule. Now, these were governor proclamations. These will all become law as of January 2021. So all of these standards were already scheduled to be coming into effect as law next January. What the governor did was just push their effective date forward. So instead of coming into effect January 1st, 2021, by proclamation, these standards are coming into effect now, when they will expire in January, and at that point, these proclamations will now become Washington state law. So there's no reason to think that any of these standards are going to go away anytime soon. Okay, so that brings us to the end. Now, let's go back to the questions. Let's see. This is a great question. So, and it perfectly segues from what we just talked about. Can you switch to telephone if telehealth platform fails? Yes, you absolutely can. And it's a good idea idea to have phone service as a backup to telehealth. The risk, though, is if you switch from a telehealth session on your telehealth platform to phone only, it's possible that now you cannot code that for reimbursement under insurance. So one suggestion is, if that were to happen, keep the telehealth platform live and just use the telephone for the audio part. And I think then you reasonably can still say, we were conducting a telehealth session, and because of audio problems, used the phone to connect for the audio portion of that. So I think that is a good idea to have telephone available as a backup to your telehealth. Yeah, and there's issues, I'm seeing a comment, there's issues about what about when a client's coverage expires and they no longer have coverage for telehealth. The very first step there would be to contact the insurance company and ask for an extension. And my guess is, especially for high-risk clients, there is so much legal liability for an insurance company to refuse that they probably would approve it, is my guess. But that would be the first place to start. Okay. What other questions do we have? We've got, how much time do we have left? Oh, it's great. We've got 19 minutes until our noon end time. What other questions are there? And just to remind everyone, put your questions into the Q&A, as I'm not monitoring the chat and the Q&A at the same time. It's just a little bit too difficult to do both of that. Let's see. Oh my goodness. Okay, so Sonia, do tribal insurance plans have to follow the Washington state laws for telehealth? Also, I've been told by a client that their union plan does not cover telehealth. Okay, two questions. I'm not sure what the union plan is. It may be an EAP, but that plan almost certainly has to now be in compliance with the Washington rule requiring telehealth
Eric,
coverage.
you know, I think it's the self-funded plans.
Ah, gotcha.
And I don't think that they are under that law.
Good point. Okay, right on. Yeah, great. So that may be not an insurance plan, but a self-funded that may be exempt. So that is absolutely possible.
Yep.
Similarly, thanks, Shannon. Great point. Similarly, with tribal plans, I got two answers for that. First one is, no, I got three answers. One, that is a great question. Number two, I don't know the answer. And number three, it is absolutely plausible that the tribal plans are exempted. They probably are from the Washington regulations. So with a tribal plan, I just don't know. And I'm going to apologize ahead of time for the pauses. I have to read the question, so that's why I'm going silent for a minute. And I need to have like some background music that I can put on that lets you know that I'm reading. Yeah, okay, so as a clinician, you may be choosing to offer only telehealth because in-person is not safe for you as a clinician. The Medicare relaxation guidelines are allowing coverage for telehealth. What happens when Medicare goes back to an exclusion for telehealth? Again, I got a bunch of answers, and the first one is I don't know. I just don't know. My other guess, though, is I cannot imagine that we are gonna see a return to the way things were. Telehealth is here to stay. I just cannot imagine when, say, Medicare is going to say telehealth is no longer indicated, in-person is perfectly safe. So I don't know. I think the bottom line is to just try and stay as up to date as you can on what the current policy is. And if telehealth becomes in some way excluded from coverage again, what we're likely to see is either an appeal on a case-by-case basis for your clients, or a need to terminate and transfer if all we are offering in our practice is telehealth, and if for some reason telehealth is not what's appropriate for that individual client. Cool question here too. Do you know if out-of-state plans are supposed to comply with the proclamation? So this proclamation applies, and the law applies to any insurance plans offering coverage in the state of Washington. This is a Washington state specific rule. Now, my sense is this is on a state by state basis, and some states are I'm sure not going to enact rules like this. Other states likely have already enacted very similar rules, and possibly the insurance companies are going to find that it's easier and more cost effective to enact these rules across the board so that they don't have to have wildly different coverage state by state. Now, that's just a guess, that there are also very different rules state by state for insurance coverage. And so the insurance companies are used to having different coverage in different states. But this will be, again, a state-by-state kind of a thing. So the insurance, the changes for insurance covering telehealth, it's relatively complicated in that the specific rules that are mandating coverage for telehealth do have expiration, but the way that they've been created is to, in essence, extend the expiration until the new law takes effect in January. So insurance companies should be required under Washington state rules to be reimbursing at the full rate for telehealth until that standard becomes law. Do EAPs cover telehealth? I don't know, and off the top of my head, I cannot tell you if the proclamation and the new law applies specifically to EAPs. I'm just not sure. Okay, next question. What are the reasonable bases to see clients in person? Yeah, so here's my answer to that. The default should be not seeing clients in person. Your default should be telehealth right now because of the potential risk. So if you are going to decide that telehealth is indicated, it needs to be on a client-by-client basis. So we need to make an individual determination that the risks of in-person are outweighed by the benefits of in-person sessions for this client. There's a whole wide range of things that might be. It might be that the client, because of their geographic, their cultural, their cognitive, their intellectual, their technological, their economic context prohibits them from connecting over telehealth. That might be a basis that in-person is appropriate. There could be clinical reasons that in-person sessions or that telehealth are not clinically feasible. But what it really needs to be is your individual determination that doing the clinical work via telehealth is not feasible to the point that the risks of in-person sessions are justified. And that's a case-by-case basis. And there is no, as far as I know, there is no existing list of here are the things that make in-person sessions justified. It's really, you have the discretion to determine that, but you need to do it on a case-by-case basis. Let's see.
Hey, Eric, I'm gonna talk. So we're getting close to the end, and I know people will start jumping off. So I just want to say thank you, everybody, for attending this webinar today. We really hope it was helpful. After the webinar, I will send out a link to an evaluation. Once you complete the evaluation, please just reply and let me know you've done it. The evaluations are anonymous, so I can't see who has completed them, and it's just honor code. So tell me you did it, and I will get your certificate out. I probably won't get all the certificates out until next week. There's about 100 people on this call, so it will just take me a little bit of time. The other thing is we are going to make a document and post it on our website. And as things change with in-person standards versus telehealth standards, we will try to keep that document as up to date as we can. And so you can always have it as a reference. And then we will also post today's training on our website as well, and we'll leave it up there for a while until it becomes outdated, and who knows when that might be. And my email is shannon@wmhca.org. And if there's ever anything that you need, please, please, please reach out to one of us at the Washington Mental Health Counselor Association. We're here. We want to support you guys, and we want to help in any way we can.
Thank you, Shannon.
You're welcome.
So I'm totally happy to keep plowing through these questions up until we hit our end point. So keep putting them up there if you've got them. Another comment that one of the things that might indicate in-person over telehealth is domestic violence or child abuse. Right on, and that is a really big one, and a very challenging, a hugely challenging situation right now, with regard to what do we do with social isolation, sequestering at home, telehealth, and abusive home situations. And that is a huge challenge that I don't have answers to, but I can say that's absolutely something to be thinking about. There's a specific question about telehealth modifiers for insurance, of whether we're supposed to use GT or 95. And I just want to read the question says, I still have confusion about modifier coding GT versus 95. I want to explicitly just respond to that statement and say, you're not alone. I think everybody does. I have no idea what the specific difference is between GT and 95, but the practical side is it kind of doesn't matter. You just do whatever your insurance companies tell you to do. There's no inherent true or right answer. You just want to follow their guidance. So if your insurance company is saying, as in this question, you can use either one, you truly can use either one. It's all about the insurance company having you document what they need you to document to reimburse. So follow the guidance of whatever the insurance company says, and it might be different for different insurance companies. Don't be concerned that if one insurance company says do GT and another insurance company says use modifier 95, don't be concerned that somebody's telling you to do something wrong. It really doesn't matter. The only thing you need to do is make sure that you are just complying with what the insurance company tells you to do. There's a question about, with telehealth, are we allowed to provide services to clients in another state? The real difficulty here is that we could talk about this for an hour and we won't. We'll just talk about it really briefly. The difficulty about providing telehealth to clients who are physically located in another state is that the rules and regulations of the state you are physically located in and the rules and regulations of the state your client is physically located in during the telehealth session both apply. And many states have rules that prohibit you from providing services to a client in their state. Some states allow it. Some states have temporary practice. Some states have notice requirements where you have to register with the state if you have a client, if you're providing services to a client in their state. That being said, things are a little bit, we need to be a little bit more flexible right now, and finding in-person services for a client who is temporarily out of the state and is temporarily in another state might be really difficult. So the bottom line is, understand that if your client is physically located in another state, that state's laws apply to regulate whether or not you can provide services. And lots of states say you can't. So at a minimum, if your client is located in another state, you need to have a plan for eventually transferring that client care to local client care, whether that means finding somebody there in the state or your client's going to return back to the state you're in and you'll be the local care. And being mindful that there is no just sort of blanket rule that allows us to cross state lines and provide services when a client is in another state. So another question about the parity laws. So the bottom line is the situation right now in Washington State is that telehealth must be covered to the same extent that in-person healthcare is covered, or telemedicine, and telemedicine services must be reimbursed at the same rate that in-person is reimbursed. There's also a comment about 2 EAPs that do cover telehealth. I'm sure many do cover it, but I don't know that they're required to cover it under the insurance rules. And Lori, your question about Tri-West is still paying less for telehealth. Is that allowed? I'm not sure if there's an exemption, a specific exemption for federal plans. There may be, in the insurance commissioner's office would be the one to ask about that. But I'm just without looking it up, I'm not quite sure. Let's see. Yeah, and privacy privacy concerns might absolutely be one reason that in-person is indicated. So a client might say, there's really no feasible way for me to have a private or confidential space to access telehealth right now. And so in-person would be indicated. That could be a rationale. It would make sense to really go through what options there are other than in person. Is there somewhere else that a client could go with their computer to have confidentiality or privacy? And the answer might be no. So that, yeah, absolutely, that is a consideration. Oh, okay, so question, this is interesting. Will telehealth likely be the default until there's a vaccine? You mentioned telehealth will be the default well into phase 3 or 4, but since smaller counties have received variances, phase 3 could start in 2 weeks in some places. Right on. Okay, so let me clarify. I am not saying that telehealth will be the standard and that will end as soon as anyone goes into phase 3. What I'm saying is, at a minimum, plan that telehealth will be the standard at least until phase 3. I think, Jill, I think your comment is probably a little bit more accurate, that I think we could really think about telehealth is the likely default until there's a vaccine, there's an effective treatment, or there's been enough exposure that in our communities we have developed basically enough immunity that COVID is not at risk of widely spreading. I mean, and all 3 of those options are likely to be a significant time away. So even if a county goes into phase 3, I think we can still consider that telehealth may be the default. Thanks for clarifying that, Joe. My biller says 95 is the most common, but TRICARE uses GT. It's funny to me because that makes sense that the most common is not the one that TRICARE is using. But right on, and that's good guidance to just have if you have a biller, that your biller is going to say, look, I know which code to use for which insurance company. And again, there's nothing inherently right or wrong. It's just do what your insurance companies tell you to do. With regard to employment rights, with a clinician who's being pressured to go into in-person services, I mean, that's a gigantic issue with all kinds of considerations. I guess the simple thing that I would say is, if you are an employer, do not pressure your employees to go back to in-person work. As an employer, you need to be offering clients and employees the option of continuing to provide the services remotely. If you have an employer who is pressuring you to provide in-person services in a way that doesn't feel safe, that's a clinical issue for you and your clients. That's also an employment issue that I would recommend really looking at in more detail before making any decisions. And I know that was not a super helpful answer, but it's a super complicated issue. And a question, can you confirm if out-of-state insurance plans such as BCBS of Illinois have to cover telehealth in Washington? I have no idea. The bottom line is, if it's an insurance plan issuing coverage to people in the state of Washington, they are subject to this rule and must comply. If it's an Illinois insurance plan issuing coverage outside of the state of Washington, and someone with that coverage happens to come to Washington, I just don't know. I don't know where the boundaries of that are. The Washington state rules apply to plans that are issued for coverage within the state of Washington. Oh, another question. Okay, so what about providing services outside of the jurisdiction that I'm in, crossing international boundaries when a client is a military member? Super complicated. The general rule is still the jurisdiction of your physical location applies, and the rules in the jurisdiction of the client's location apply. But the thing that makes it different is internationally, it's less of a concern. Number one, many countries do not regulate counseling, so there isn't a local set of rules to apply. And the second thing is, if your client, for example, is deployed to Afghanistan and you're providing counseling to your client who's in Afghanistan and you're violating some practice requirement under Afghani law, you probably don't care, because you're probably not going to go there and be subject to their jurisdiction. So the standard is the same. You got to comply with both jurisdictions, but it probably matters a whole lot less. And again, same thing if you are close to the Oregon-Washington border, you've got clients crossing that border, it's all about where your client physically is located during the session. Where the state that your client is physically located in at the time of the session, that's the laws that apply. Okay, we're slightly over noon, so we're out of time. I know there are some questions that I didn't answer. If you still have a question that wasn't asked, feel free, there's the email address. Feel free to email it to me in either the subject line or in the email itself. Just reference this training so I have sort of a context for it, but I'm absolutely happy to answer your questions offline. So thanks everybody, and thank you for all the interaction and the questions. That really makes it more useful and enjoyable. So thank you everybody, and have a great weekend.